Good evening, everyone. This is Dr. Ashok, the moderator of the session. The session is going to be near misses in the emergency department. The speaker is my good friend and my postgraduate mate. We both hail from the same medical college, and he's a versatile speaker from Madurai Apollo Hospital, who is a senior consultant in emergency department and head of the department. I welcome you, Dr. Jude, for the presentation. Along with this, I sincerely thank Yashoda Hospital for doing this program regularly and educating all the emergency colleagues around the world. Thanks to Dr. Konli Raghu and Dr. Srinath. Thank you. You are good to go, Dr. Jude.
Thank you so much, Dr. Ashok. Am I audible?
Yes, you are audible. You can go.
Okay. Um, Thanks a lot for inviting me as a guest speaker in this wonderful program. Thanks to Dr. Srinath and Dr. Raghu and the organizing team of Yashoda Hospitals. We are going to see a case series about the near misses in emergency department. It's actually, by definition, it's an event or situation that could have harmed a patient, but it didn't due to the chance, by chance, or a timely intervention that you have done, or you have by your early detection of the particular risk, and you have changed your course of action so that the patient has been saved. So this is a near miss. This is not uncommon. It's quite common actually in a busy ER, but it's actually underreported in fear of reputation of a corporate or in fear of reputation of a particular department or a working personnel, a people, a team, and all those things. It's significantly influenced by a workforce of a particular department that's in ER in a particular point of time. Say, for example, in a busy ER, instead of having 4 nurses, you are having 2 nurses on that particular shift. Or instead of having some 3 residents, you are having only 1 resident at a particular point of time. So this is the vulnerable period. So the near misses will be happening in this particular time. So this is categorized by places. Say, for example, it can happen either inside the ED or in outside the ED. That means it can be happening in the ambulance also. The delay due to overcrowding could be a major factor for near miss. Similarly, it may reflect in the medication administrations and all those things. So we are going to go through a collection of random real case scenarios, which has happened in variable time period over the past 20 years. This is a 54-year-old guy who walked into a busy ER the evening, gripping his chest. It's very classical kind of symptom. It's a very common, quite finding what you have already faced in so many times in your lifetime. The pain started an hour ago, which is sharp, leading to the left arm. He's a diabetic and smoker. A significant risk factors, both of them are, but he's physically active. Vitals didn't show any major changes or any major abnormalities. So this is it's an easy diagnosis to us, right? It could be a acute coronary syndrome. But surprisingly, the ECG is normal. The enzymes are negative. Echo is normal. The cardiologist was consulted. He considered the classical clinical picture and he planned for CAG because this is this is a quite common scenario, right? The ECG can be normal, echo can be normal, but clinically, if it implicates that this could be an ACS, you will be going according to your own protocol, which can be suggesting a proper evaluation of ACS. So he was loaded with aspirin, clopidogrel, atorvastatin as per the routine local protocol. Now, what happened was while getting shifted to CAT, we will change the gown, right? The hospital gown was changed. The nurse casually moved the pulse ox to the left hand, and suddenly the SpO2 dipped down to 78%. So initially we thought that it could be because of the improper trace of the waveform, so it was rechecked. When we checked to the right hand, it was again 98. When we checked into the left hand, where he complained pain, it is 78%. Could this be a monitoring error or it's a clue for something else? That's the question that we had. So the left radial pulse now when we felt it's feeble and the arm felt cooler compared to the right when we touched. So this was not focused earlier upon. So now everyone have a ultrasound, so you can clearly see a monophasic waveform pattern here in the Doppler, which can be easily picked up by any resident in ER. So this significantly tells that the radial artery is totally almost locked to the near severe extent. So it's actually a PAOD. He's a smoker with acute limb ischemia. But the presentation is not very classical of the classical pain which you usually encounter with in case of acute limb ischemia. So then the vascular surgery was consulted and then the urgent intervention was planned and the limb was saved. So the chest pain need not be always cardiac. The interpretation can be different. Usually, you should have a habit of checking bilateral SpO2 and pulses whenever the patient is having some kind of limb pain. We do if you suspect, but when you don't have a classical clinical presentation, make a habit of checking bilateral pulses and BP and saturations, and especially whenever you are in doubt. So usually we say that don't treat numbers, don't treat the monitors, see clinically. Sometimes the clinical judgment can go into a different aspects. At that time, please depend on your tools, your monitors, and sometimes that can help you too. The basic monitors can save limbs and sometimes life. This 41-year-old male, a corporate employee, father of two beautiful daughters, he had a sudden onset of headache. He described it as pounding, severe, and centered over the forehead. It's actually followed by a stressful day, and he is a known migrainer. He was prescribed by one of the neurologists of ours. He took some acute migraine treatment medications, but he was not willing to continue the migraine prophylaxis, which is being prescribed for a longer time in fear of some side effects. So he didn't take those prophylactic medications. There was no associated symptoms like vomiting, visual or no focal deficits, which is usually we do as a routine dictum for any neurological case. So this kind of this headache is very usual to him. The severe nature, the tendency after which he gets, all these things are very similar. Vitals were quite normal. GCS is quite good. The examination is unremarkable. So as there are no red flags, or it seemed to be no red flags, and we didn't image him, we didn't suggest also. So the final impression is migraine attack. We suggested him to follow with the same neurologist in the OPD. We informed the neurology OP, and then he was shifted. The headache became better after some IV paracetamol and some basic medications. He was rushed back to ER within few minutes from OPD with the GCS of 8 by 15. Pupils were sluggish now. BP was shooting up to the sky, and brainstem reflexes were dull now. So now we know that something is wrong, right? So we took a CT and it came out to be a ruptured cerebral aneurysm in angio. He treated and luckily recovered later. So the first and last warning symptom was that same typical migraine that he had for years. So don't anchor on your past diagnosis. So migraines doesn't make a person immune from the new pathology. Say, for example, the migraineurs are usually tend to have, they are prone to develop more kind of acute neurovascular syndromes, including hemorrhage and stroke and everything. So there are so many papers on it. So any sudden, severe, first time, unusual, intense headache is SAH, but in this case, it's a pain that he is already used to. But usually, theoretically, the textbook description is like this. You know that. Imaging is mandatory if there's even a whisper of small warning. So don't miss the imaging if you have some kind of alarm in your mind. This is a 36-year-old female doctor. She was traveling from north, I think from UP in my distant memory. She had come for some kind of pilgrimage. She had a one-day history of loose stool and vomiting, very mild grade fever with some kind of vague abdomen discomfort. She is a known hypertensive. She was on telmisartan on 40 milligram OD. Otherwise, she is healthy. Her BP is 100 by 60, probably because of the dehydration that she had. The heart rate was 64 per minute, Tachycardia was not there. Temperature 98.4 is normal. It was looked like AGE. She was treated symptomatically. She herself gave some orders to all the residents. That means, give me this, give me that. It's a common problem with doctors, right? So she suggested so many treatments, and we denied some of them, and we accepted some of them, and then she was treated symptomatically. As the patient was preparing to leave ER after she improved symptomatically, she experienced a very brief LOC. That means very short span of probably for 5 to 6 seconds. Now she was brought into ER and she was checked with the BP is 80/60, heart rate was 56 minutes. So given this combination of bradycardia and hypotension, we knew that something is not correct. It's not just a simple AGE. But she now also she told this is just a postural hypotension. Please let me allow to go out of this AR. I want to go out immediately. But we compelled with the attender that she has to undergo ECG, for which the doctor is unwilling also. Then this is what seen in the ECG. And there's no need to explain what's happening in 2-3 AVF. Now, she was loaded with all the routine antiplatelets, statins. The cardiologist was involved. CAG was performed, where we found that she had a severe triple vessel disease with 98% occlusion on the RCA. And it was stented successfully, and she went out with a happy face. Young people are not immune to acute coronary syndrome. This factor you know already. Sticking on to simple diagnostic bias can kill. The patient is having an AGE, it can be straightforward AGE in a busy ER. So we may not be able to think of all the differential diagnoses that we have to consider. Bradycardia with hypotension, always you have to think of inferior MI in case of ACS. And LOC is not a simple sign. It's not a simple postural symptoms. It could be a red flag for any patient for any matter. This 48-year-old male was rushed by his family. He was visibly breathless, profusely sweating. He was not even able to tell what he is undergoing. The attendant was very anxious as usual, and he was saying that he has been having chest pain and talking something weird for the past 2 hours. We went to some nearby hospital and they sent here, please help. BP is slightly on the higher side, tachycardic, saturation and respiratory rate as shown in the picture. He had bilateral basal crypts, for which we thought that it could be because of early pulmonary edema, which can be a usual complication of ACS. There's no known comorbidities. He was groaning softly, clutching his chest. This is a classical presentation of any ACS. This is the ECG, where you can see extensive anterior MI. It's a very classical presentation. There is no difficulty in diagnosing this case. We repeated a ECG as a formality, which showed the same change. There is no major progression or coming down of ST elevation. So it was termed as ACS, and then what we do, the plan of action is like this, right? Usually we push the patient for PCA, but in this case, the attenders were not prepared. There were some financial constraints in the attenders where somewhat the attender was afraid to undergo PCA. Some blah blah is there. So we discussed with the cardiologist and we were about to go for lysis. The attender can't recall if he was given any loading dose elsewhere. So we are in doubt. The only clue what we had, we went to the hospital earlier, but they told us to rush here. After giving some medicines, but there were no papers or bills at that point of time. Now, just before we loaded, actually, we loaded TNK. He was around 70 kg. So we got a 40 milligram of tonic place and we loaded 35 milligram with 7 ml of NS and is about to push. Incidentally, patient was observed to have minimal bleeding of gums in the angle of mouth. So now we knew that something is wrong. The patient is not having bills. The patient is not having any kind of reports from the outside hospital. Actually, there was no number for the hospital also. So we tried. It was not in the referral list. So we got somehow the list and then the number and then we tried. So they were telling in a cold, calm manner that yes, we gave him streptococcus an hour ago. So it's a failed lysis and then we pushed the patient into PCA. We We convince them that this won't work and it may kill the patient. So we have to go about with class T, and the patient accepted now, and then the patient was taken up for rescue PCI. So when the patient attenders lacks knowledge about the treatment details, reconsider your decisions. When there is a significant documentation gap exists, try to check bills. Early communication with the referral hospitals may change the course of your treatment, and any atypical bleeding signs should be definitely addressed. You have to see from top to bottom of the patient and expose the patient, and then you can make a call before making a major decision. This is a youngster brought at around the lunchtime. It's 2 p.m. is the changeover time for the consultants. I will be handing over to the other consultant at the time. So he was riding a two-wheeler at high speed. He lost control and hit a roadside barricade. This picture is not the original picture. It's a picture taken from the net. The complaint was he had very minimal pain on the left side, no loss of consciousness, BP 120 by 60 millimeters of mercury. Heart rate is okay, saturations are good. He had a very minimal abrasion in the left mid chest on exposure. Air entry was good. Very simple tenderness, similar mild tenderness in the left mid zone around some third rib to sixth rib. That's what I remember vaguely. Abdomen was soft, it was non-tender. GCS was good. Fast is negative. This is the routine that we do in emergency department. You also know about all these protocols. We took a basic X-ray and it was the fourth rib fracture on the left side. The patient was completely okay, fine. It looked clean. So we thought that we will reduce the pain, we will hydrate him, we'll observe for some time, and then we shift to ward for observation. He was started on IV fluids, PPIs, antiemetics, analgesics. Then he was observed for 2 hours in emergency room. Was shifted to ward, which is a routine after some consultant came and see the patient. That means the primary consultant who under whom he is getting admitted. Patient was stable. He was sleeping comfortably at the time of shifting. In the time around 8 hours, the patient came at 2 o'clock. He was shifted around 4:30, and the midnight we had a call. The med call got activated. He was found drowsy, tachycardic, BP 150, heart rate is 115, pale cold extremities, mild abdominal fullness was noted. You know what is there? No need to explain that. Now the fast was repeated and it shows on the left side this kind of free fluid. So CT abdomen was ordered. The splenic laceration was found. He was rushed to OT. Splenectomy was performed, and he was transfused multiple PRBCs and FFPs. He required a prolonged ICU stay, and ultimately he survived and discharged in a stable condition. So please keep in mind that negative fast scans do not exclude an abdominal injury. That's very, very important. So it's a screening tool, not a definitive diagnostic methodology. So normal fast doesn't mean that there is no injury. You have to repeat fast whenever needed. Left chest trauma, think of spleen. Right chest trauma, even though it's not in the lower ribs, think of liver. The patient has to be observed for at least 12 to 48 hours in high velocity blunt trauma. It's a rule. This 51-year-old male came in the first day evening around 5:45 p.m. He was a known hypertensive. He is highly connected to some of the VIPs, which is known to the hospital management. That's the major history that you have to note always when you work in a corporate. So he had a burning sensation right there. He says, pointing in the epigastrium. No sweating, no associated warning signs. BP is fine, heart rate is fine, and the saturation is good. This is the initial ECG. We did the echo because we don't want to miss anything because this patient is somewhat connected to many persons. Echo was normal. He was treated as APD with PPIs. Within 20 minutes, with IV rabiprazole and prokinetics, he felt much better. We advised admission as a routine for observation and to do a serial enzyme. The initial enzyme was okay. He declined. I'm feeling better now. Tests are normal. What's the need to stay then, right? The way he asked was appearing to be, why are you pushing me in? You want to earn some money out of me? That's the way he asked. So what we suggested was, Okay, it's your choice. So please go and attend the cardiac OP and medical gastro OP because I want to protect myself. And this guy went out of ER and he never showed up. He didn't go to cardiology. He didn't go to medical gastroenterology also. 6 o'clock in the early morning next day, this man returned with paleness, sweating, clutching his chest, pain in the left arm. He has already vomited 3 times. Now the ECG is like this, and the echo showed complete akinesia of the anteroseptum with anterior segments at distal IVS and left LV apex. EF now gone down to 35%. So he had a double vessel disease and LAD reconstruction done. Luckily, he too survived. But he gave a big letter as expected against the Department of Emergency Medicine saying that these guys didn't guide me well. They just guided me. Just you can, if you want, you can go to cardiology OP. There's nothing to worry about. So I went out. That's what he told by writing. Remember that the strict advice for admission and observation is mandatory whenever there is a doubt. So if the patient is not obeying, get a consent against medical advice and follow up with OP. The patient is not going there, just document it. Serial ECG enzymes and echo in high suspicion is always mandatory. A 62-year-old male brought by his son. He was telling that he had a heart attack, having chest pain since 3 hours, was treated by a nearby clinic. They told that he requires an angiogram. That's what his son uttered. He was a known diabetic, now sweating, and he has vomited once. Vitals were relatively stable except for the tachycardia of more than 100 per minute. Sugars were well under control. So the ECG was showing the classical pattern of anteroseptal MI with some reciprocal changes in the inferior wall MI, that's inferior wall. The diagnosis and patient status and the need for primary PCA was discussed with the cardiologist through the phone. The cardiologists were always busy, and so he was in cath lab doing some other case. He advised to prepare the patient for immediate PTCA. So the patient preparation was done with simultaneous evaluation in ER to complete the formalities. That's ECG, echo. We will do a package called as angio profile 1. That means the routine package of some blood tests, collection of blood tests, which required by the cardiologist. It's called as AP1. And all these things were started in ER. Our routine ECG is like this. It didn't show anything. So what could be the possibilities? Sometimes they would have loaded him with antiplatelets. It could have recanalized. They would have given some heparin. So what could be the? He was not lysed probably. So in this case, we have checked it. So what could be the possible spontaneous recanalization? So all these things can be considered. Trop is negative. The high sensitive troponins can pick up very early all these elevations. Echo, there is no regional wall motion abnormality. So what could have happened? This is the question that arose. So we were a bit hesitant to push the patient in. Now the resident was asked to go through the previous records. Now he's saying to me, the intelligent resident saying to me that, sir, this outside ECG mentions his name as Karthik Selvan, but this guy is saying his name as Karthik Kumaran. Now there's an alarm. So the referral clinic was called back and they came to know about the change of identity with two similar named patients with similar symptoms, almost similar symptoms, who are lying in nearby beds. This has happened to a patient, which can happen to any one of us. So it's basically an identity error. The wrong ECG was sent along with the patient. The another patient was not referred here. He was referred to some other center. So this report was acted upon. The outcome, the patient didn't have MI as mentioned by the patient attender. It turned out to be a severe esophageal spasm and GERD. So unnecessary intervention was withheld just in time. He was treated symptomatically, counseled, reissued, and admitted for observation. So patient identity verification, you know that that's very, very important in emergency room, but which is usually taken for granted by a resident or even sometimes by the consultant. In a busy ER, it's always difficult to check all the identities, but it's very, very important to avoid the near misses. Never blindly trust outside investigations. So think clinically, don't get biased by the outside diagnosis. This guy, a 48-year-old one, walking in, supported by the attender. He was dragging his right leg. These family members, they are all they were all attending a marriage. It's a family function actually. So his nervous center started an hour ago. He suddenly couldn't move his right side limbs, not talking properly. Actually, it was about the time where that they are tying that thali at the time. So they had some time. They wanted, some people tell that just wait. Sometime there are some 10 minutes or there. Please wait. And it's just a small weakness. He will be okay. So that's why it started an hour. That's his nervous and was saying that. He was a known diabetic and hypertensive, which can be sufficient enough to push the patient into a stroke. And maybe a CAD, some kind of heart issues, and he was in conservative management. That's what the son told. The right upper and lower limb power was 2 by 5. He was aphasic actually. So, as many of you have the systematic uh, code stroke in your ER, we are also having a code stroke which is activated. It's a clear green corridor. It's a clean slate for us. It's a simple thing that the routine things will be happening in the next moment, tuck, like that. So CT brain revealed no hemorrhage. The checklist for contraction was clean sheet, and IV thrombolysis TNK was done immediately. That means within a matter of time. So everything is so far by the book as for now. Now, moments after thrombolysis, a detailed history was taken again for documentation purpose. Now the wife has arrived. Wife was not initially there. The son brought his father. The wife, because of the function, he came little late. Now, she is saying that this patient is having some kind of heart valve problem, undergoing some blood investigation every month. So I know that something is missed here. She was carrying a bag with some medications. You know what's that medicine? Everyone knows, even LKG kid knows what's the medicine could be. Okay, then. Now the heart rate rises not for the patient but for the doctors. Everybody is in the emergency department. Did he take it recently? Was it missed in the history? Did we just lyse a patient with who are anticoagulants without checking the INR? All these questions were getting shooted up. The blame game just started. So with the stat, INR is ordered, and luckily it turned out to be 1.1. Thank God. So now discuss with the wife for the person. Now she is saying, yes, sir, he was on that, must have stopped it by himself due to some busy schedule in the marriage works. Okay, that's good. If it is more than 1.7, if he started bleeding, then the story could have been completely different. Medication history must be taken from the closest caregiver. That's very, very important. One hidden tablet can kill the patient. The contradiction checklist, which is given by the AHA or ACA, should be tailor-made according to your own experience and protocols and according to the local crowd. So if medication history is uncertain, INR is always to be done. Then we made it as a practice. This happened 10 to 12 years back when we started in the initial days of thrombolysis. Now the thrombolysis has been taken some back foot. Now everybody is pushing the patient into mechanical thrombectomy. So hypoglycemia mimicking stroke, that could be a near miss. So classical presentation of one-sided unilateral weakness of upper limb and lower limb could have been the initial presentation of a simple hypoglycemia. So it need not be a stroke at all. So all these things could be kept in mind. A known alcoholic and depressive disorder. He was drowsy and disoriented with multiple small abrasions across all his limbs, was brought to ER, but his wife cheers. Sir, he was taking his routine drink at the backyard. He's an alcoholic, so usually takes a peg in the backyard. He fell down from the chair. He was tachycardic, tachypneic. BP is 120/70. SpO2 was 94 percentage. GS 12 by 15. He had very mild crepitations, like some kind of aspiration kind of crepitations, more towards the expiratory phase. and some it's not very classical of the pulmonary edema kind of volume overload kind of crepitations. The disease discussed were could be a overdose or any alcohol intoxication or some encephalopathy. It could be some metabolic. He's a chronic alcoholic. General examination didn't reveal anything significantly, apparently. That means by the resident. Sometimes you have to depend on the resident who is the senior, and you can't go and, as a consultant, you can't go and check each and every corner of the patient. All basic labs and imaging are normal. Brain imaging is clear. There's nothing significant. Within an hour, his GCS dropped to 8 by 15. He had some labored breathing, sweating, and 112 per minute heart rate, BP shooting up to 180 by 100. Some kind of autonomic instability he had. He was intubated immediately in view of impending respiratory arrest. He was not breathing well. His efforts are very poor. He was bad at that time. Now, a more focused repeat limb examination from head to toe after intubation, among the muddy abrasions revealed two small puncture marks. This is not a new case actually. Every one of us could have gone through some similar kind of snake bites in the past in your department. But the story is different, but the issue is a snake bite. So could we have missed a bite? It's very well can be. A sudden neurological deterioration, a silent onset overnight, no signs of major trauma, clean scans, and autonomic instability can always warn you that it could be a neurotoxic snake bite. He improved within 48 hours and then extubated with proper treatment protocols, and he was discharged after a few days. Just because he's an alcoholic and depressive disorder doesn't mean overdose. Early labs can be misleading in envenomation, so you have to stay vigilant. A full body examination when you don't have a clue is not optional, it is life saving, it is mandatory. The complete exposure and head to toe examination is mandatory for all emergency residents. Crate bite especially can be painless, it can be invisible, and can be lethal if you miss it. This is the last one. She's a 50-year-old female. She's a wife of High Court judge. That's an important history that we have to collect. Wives of judges. Known diabetic, hypertensive, and CAD. Sudden onset left upper and lower limb weakness for 4 hours. He's on the verge of recommended window period. You know that. So you have to rush for things if you want to lyse. The heart rate was 90, BP 100 by 70, respiratory rate is okay, saturation is 98, borderline, blood sugar is 96. CT brain was done within minutes, as I told you, it's a code stroke. Checklist was cleared. There was no contraindications. TNK made available. Radiologist calls back shortly. She was a new joinee, young female. It's a yearly ischemic stroke, no hemorrhage. That's what she uttered to the resident in the phone. So we immediately discussed the neurologist. The neurologist was on the way, but you don't usually wait for them, right? So we have to do the lysis and IV thrombosis. It's a routine protocol thing that we do usually. So the ER takes over here and it lysed. Now, just a few minutes later, immediately after the TNK push, there was another tring. Now the residents takes the call, and he was very happy to talk to the radiologist. So he was something she was asking from the other side, and this guy says that yes, ma'am, we did thrombolysis immediately as per your report. Now this, can you guess what she told? Now she's saying to this guy, and he's repeating it to me. Sir, she says that there's a small hypertensive area in the basal ganglia, possibly a minor bleed. Can you hold lysis for a second? I will just confirm with the senior and then I will come to you in another few minutes. Now, the neurologist is running into the ER with the same question. Have you lysed? What happened to the scan and all those things? The ER team stares blankly at each other. We have already lysed him. No. We have killed him. No. We have lysed him. Sorry. Shocking. Did we traumatize a hemorrhagic stroke? That's what the question that we were having at the time. Now, whom to blame? My co-consultant, who is associate consultant, Dr. Madan, was looking at me. Who is going to jail for this wife of the judge? It's you or me? That's what the question we had. You know what happened? That review of the scan after the senior's involvement, they were very conclusive that it's not a bleed and it's just a calcification. So cross-check radiological findings if borderline or doubtful. The expert opinion saves lives and prevents this unnecessary panic. So usually it's better to have a habit of having a look at the film by your own. But when time constraint is there, on the verge of window periods, this can happen. A proper communication between departments, ER, radiology, neurology, is critical in time-sensitive decisions. The calcifications can mimic hemorrhage on non-contrast CT. So you have to interpret with clinical context and some kind of senior inputs. So I'm just winding up here to sum up. A near miss can go into an actual miss or a total miss. So if you don't report or don't document any near miss, that means either the ER is not a fully functioning ER or you are lying. So it's okay to not to document in view of the reputation, but it's not okay. That means if you fail to recognize that. Don't go with previous labels on diagnosis and don't get yourself misguided by the previous diagnosis and investigations. Always double check when the patient has been partially evaluated outside in your of your ER or your center. Only the repeated clinical assessments and judgment will be the key to avoid the near miss. With the words, I'm just winding up. Once again, I thank you for the wonderful opportunity to share the views about near miss in this wonderful series. Thanks to Dr. Srinath and Dr. Raghu, and a very special thanks to Dr. Ashok. And I just wind up here to give some words and suggestions or your views about this. Thanks, Dr. Ashok. Thank you. You can take over.
Yeah. Thank you, Dr. Jude. That was a fantastic presentation, which could bring out all your experience of all these good years. And you are trying to pinpoint each and every minute decisions which the ER physician has to be extremely careful before doing it. And a ER physician is always under tremendous pressure, who will not be able to take a good decision at the time of stress or a crowded ER or a mass casualty, or sometimes the pressure from the management side also. So it is up to you to decide what has to be done the best for the patient. And very importantly, you have to protect yourself first. That's very important, because sometimes your decision may be favorable to the management but harmful to you. So you have to protect yourself. When in trouble, the management may not be able to support you. You may be even asked to check out your job. So be careful before taking any decisions. This has happened to many of our colleagues also. So before doing it, be careful. And the next thing is, be careful with the medico legal decisions. Whenever it has to be done, you have to do it. You may have threat from the police people or from the patient or from the attenders, but what is legally has to be done, please do it. Don't ignore that. And documentation is also very important. There is not much for me to say, because Dr. Jude has covered everything whatever you people have to know. Especially a simple hemoglobin test during a hypovolemic shock, during a polytrauma may mislead you. It may be normal in the initial hours, which may be very low in the late hours. So simple things like this, hyperkalemia has to be checked in a crush injury, severe abdomen pain, you have to rule out mesenteric artery ischemia, a patient who is having a very high blood pressure with a simple giddiness, you have to take a CT. A patient with a chest pain, with the STD changes in all the leads, rule out aortic dissection. So you think the worst of the worst. Sometimes your primary consultant or co-consultant may be unhappy with you. For a simple abdomen pain, you are thinking about MI. This has happened many times. Yes, I said it could be MI, and later it may be a gastritis. That's fine, but you have to think the extreme of the disease pattern. You have to have a high index of suspicion. That's very important for a ER physician. Thank you all for listening patiently. Thank you, Jude. Thank you for the organizers, Dr. Srinath and Dr. Raghu.
Thank you so much.